So hello, everyone. Welcome to the School of Health Information Science Health Terminology Standards June Seminar Series. My name is Francis Lau, and I'm a professor at the school. This seminar series is part of the Health Terminology Standards Certificate Program that is offered by the school. First, from where I am in Victoria, I wish to acknowledge and respect the Algonquin peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and Wasanich peoples, whose historical relationships with the land continues to this day. Tonight, we're pleased to have Dr. Morgan Price with us to give a seminar on health system improvement. Can standards help? Just quickly, Morgan is a family physician and practices in a community health center where he provides team-based care to underserved populations in the inner city, Victoria. His research is in health systems change and clinical information systems design. Just before we begin, a few housekeeping items. Please note that the session will be recorded for sharing on the school website afterwards. Please use the chat box to type in questions or comments at any time during the session, or raise your hand to ask questions or make comments after the presentation. There will be time at the end of the session to address your questions and comments. So at this point, I'm going to turn the microphone over to Morgan. I'll stop sharing. Take it away, Morgan.
Great, thank you. I'm going to start sharing, and then we can get started. So there, we should be able to see my opening slide.
Yes.
And I'm going to just start by saying, Francis, thank you. We've done a lot of guest lectures over the years, and it's fun to come back to him and share a little bit and learn from the group as to what's happening. Keep me up to date a little bit, which is great. So Francis introduced me. I'm Morgan Price, and I'm going to do a little bit more formal, but I wanted to start off with a little bit of proof that I've been involved with standards. And in British Columbia, I helped establish the DATE standard in healthcare a number of years ago. So the official best way to frame it, according to BC, is what I have on my slide today. I too want to acknowledge where I am. I'm also in the traditional territories of the Lekwungen-speaking people. And I'm blessed to be here. It's a wonderful space, and I also feel attachment to the land. So first off, who am I? Yeah, I am a family doctor. I've been working for 20 years in the inner city, initially in Vancouver and then here in Victoria for the last 15 plus. I'm an EMR user, so I have some experience from that perspective as well. I have a PhD, thanks to Francis, in health information science. And that has sort of springboarded my work into research in a bunch of different ways. And currently I'm associate head in the Department of Family Practice and the director for the Innovation Support Unit. I'm cross-appointed at UVic because I'm part of the Island Medical Program. So I'm actually in Victoria, and I'm connected into the Division of Medical Sciences, Software Engineering and Computer Science, and of course, Health Information Science. So here are my ground rules. I always say that I'm not going to try to skate around things as long as you guys don't throw rocks, and do interrupt me with questions. I will try to monitor the chat. If I missed it, just jump in, and it's a small group, so feel free to jump off mute and then just let me, fire a question away. Way better for us to have a useful conversation for you than for me to feel like I got through all my slides. The slides are there sort of as signposts for myself, but really I want to have the conversation that's valuable for you. And if there's anything that I can impart as a guest lecturer, then I'm happy to sort of tangent around to where you need me to go, or where you want me to go. Having said that, I thought I'd start off with a horror story because it's always good to have one of those, and then talk about why standards are important from my perspective and experience. Thinking about it across 6 different contexts relative to primary care. And then there should be plenty of room at the end for discussion, but if we use that time during, I think that's even better. So again, feel free to interrupt. I'm going to start off first, before all that, with a question to you. So what is the standard joke about standards? At this point, you're taking the certificate program. You should know the standard joke. Does anybody, Francis must know this one, but
Oh, I was actually just going to ask if people want to speak up.
Yeah, please. Anybody jump in.
I don't see any takers. Is that the one where someone thought they wanted to standardize all the standards, so they introduced one standard and now
That
they
is
have
right.
one more standard?
Yeah, exactly.
I
Yeah,
probably bastardized that one.
The good thing about standards is that there's so many of them, right? Or there were 12 standards, so we standardized them by adding a 13th. That is really the one joke that you ever hear is like there's just because there's so many of them, and we'll get into that as we go along. But my story is a personal story, and it goes back a few years now. So I was in Vancouver, moving back to Victoria, and I was sort of embarrassingly, I was in a paper-based practice while I was actually teaching informatics to family medicine residents and medical students. So I got involved really early on with an interest in informatics, and then started to step into some teaching roles. And I was talking about all the benefits of an electronic record and all the things you can do with it. And yet the clinic that I was working in the inner city was still paper-based. And it was a little bit embarrassing. I helped try to push the health authority to get an EMR, and that process took quite a long time. Such a long time, in fact, that they hadn't yet implemented the selected EMR by the time I decided to move home with my wife and start our family. But when I moved to Victoria, I found this wonderful community health center here, and they had an EMR. And in fact, they had an EMR for a number of years already. So I was super excited. And this was finally an opportunity for me to roll up my sleeves, not just in theory and not just at the hospital, where I've done some informatics work as well, but I could do it in my own practice. And that was great. So I walked in, super keen. And this was my first experience. So it wasn't great. Sorry, I'll just jump ahead there. We did have a record, but it wasn't exactly what I was hoping for. Functionality-wise, there's some things, but from a data perspective, there were some challenges. And I feel like I can share this stuff because it is from my office. So we're an inner city clinic. One of the things that we treat a lot, a bunch of things we treat a lot that are different than your typical family doctor's office. In the inner city, a lot of the chronic illnesses that we manage are around substance use, mental health, hepatitis. We have a relatively large population of HIV patients. We actually treat the majority of HIV patients on the island through our clinic. And so those are some of the areas. And, we have less traditional chronic disease, diabetes, and congestive heart failure. So here's an example of some of the data standards in our office. And I do want people to just jump in, please. This will go very fast if we don't. And just sort of highlight some of the things that jump out on this list. So this list is a list of diagnoses that if I'm putting a diagnosis on the problem list or an encounter note, I can pull from our standardized list of terms. And these are some of the ones that popped up. So does anything jump out there to anybody?
For example, the VE 2003, 2001. That's something
Right. So an interesting, like a little note there, a plus sign VE. So that's positive. And then the date of when the diagnosis was.
Basically trying to say the same thing in like 20 different languages.
Yeah, Marie, very, very much so. There's all that like PCR positive. That's technically, it's a lab test. So a PCR test looking for the genetic material of the hepatitis C virus. So they've embedded a lab test value into the problem list disease diagnosis, which is supposed to be this standardized list. And then the next one is they've added a date of the lab test in the diagnosis table. And these are from the table. These aren't just things that are written in a note somewhere. These are actually were in the database. I say were because we've done some cleanup, but they were in the database table. Any other ones out of that list alone that jump out? Because I've got two more to highlight. One is that genotyping is important, and there's actually multiple genotypes written in there, and that's a subtype of hepatitis C. And I don't expect everyone to know that, but is really important for us from a treatment perspective, because genotypes 1A and B were traditionally quite a different treatment protocol than 2 and others. So that is an important thing that actually is not in the data standard that we have access to in our EMR. So it was augmenting with reason our data set, our list. The other two I'll say is the cirrhosis is another different diagnosis, related, but actually technically different. So someone's mashed those two ideas up. And the last one that I think is really critical is hepatitis C PCR negative. So technically, if you're a PCR negative, you do not have hepatitis C. So it's actually the opposite. And yet, if you search for hep C, it's going to show up.
There's also a comment from someone that the bottom hepatitis is not capitalized. Does that
Absolutely.
matter?
It could. And that's a great thing to point out, because so Desmond, that's great, because look at where we go next. Well, I'm going to jump back to hepatitis in a second. Here's another list. And so cellulitis is a common skin condition. It's an infection. And what our EMR does really well is it shows you the code. And if you notice in the sort of the right-hand side of the screen capture, there's a thin gray line. And on the left hand is the words. And then on the right-hand side are the codes that are associated with that. But there's no numbers. So here's another example where there's a few numbers. So what had happened is that the EMR vendor had pulled codes from multiple other early adopters of their EMR and took the terms that they used and just dumped them into the database. So they had more terms because people were asking for more terms, but they weren't connected to any terminology sets or even in particular codes. So they, again, from a standards perspective, you didn't have anything to access except for the spelling if you knew what to look for. Here's another one. So we do a lot of substance use, and there are several there that should be coded that aren't. And then to Desmond, a little bit to your point, the last two with an E in heroin is very different if you think about what it actually means. And my wife will tell you that I rely on her an awful lot, and so therefore I must have heroin dependency with an E. I hope you got the joke. A couple other ones. It's just some very strange things. So the first one, I'm not quite sure what it was supposed to mean. It has all the problems, not capitalized, misspelled. It's somehow some other kind of condition, and it's still a negative test. And then and it doesn't have a code. The last one, hepatitis, is I think some sort of classic Greek or Roman tragedy, a character from that. And these were in our database. We had over 34 misspellings of hepatitis. And we've since cleaned that up, which is great. But it is something that is very, very real in many systems. And the standard was there, but it wasn't always utilized, as you saw. And we weren't alone. I started to look at stuff and using my knowledge of informatics and some of the data that we had available to us and the standardized material that came from the labs, or our lab tests were coming in a standardized format. I could ask questions like, how many of our diabetics have an A1C test? And the time we did this study, an A1C test was a way to monitor the diabetic control of a diabetic. So it's a particular blood test that looks at about 2 to 3 months of average control of sugar in the bloodstream of a diabetic. Too high suggests that we need to make some changes to treatment. Rarely is it too low, but occasionally it can be. And that often suggests that we're too tightly controlled and we're actually getting people having low blood sugar. And so there's another risk there. So I thought to myself, great, this will be an easy one. We teach residents about the importance of this and how to do quality improvement. So let's do one of those. So I wanted to find out how many diabetics have had an A1C in the last 6 months. So I looked for diabetics. So DM is diabetes mellitus on the problem list. First, how many diabetics do we have? Found a little over 100. We have a fairly large practice, but like I said, this is not all that common for us relative to the average practice. But so we had 110, give or take, patients diagnosed on the problem list in their chart so you could read it. And when you refer them to a specialist, it would show up as a problem in the referral that we sent. And then I started thinking about this. I go, I wonder how many have we recorded have diabetes through our billing system, which uses a similar data standard, but we can't submit a bill. It actually uses the same list, but we can't submit a bill without a code. And we have to put at least one diagnostic code, otherwise we can't submit the bill. So lo and behold, we're about 125, 130 who had it in their billing, and so clearly the problem list isn't quite as good. And then I thought, well, what about a fasting glucose? So let's look at fasting glucose. How many people had a fasting glucose over 7? At the time, that was essentially diagnostic criteria. And we had over 150. We had closer to 175. And then lastly, how many people had an A1C test, period? We don't care about the diagnosis now. And we had well over 225. We had double the number of people who had A1C tests to monitor diabetes than we had people who had it written in their chart. So this is my sort of early awakening at a very close level to data quality issues, partially related to data standards and the use of those data standards. So the poor use of the existing standards meant that we really couldn't start answering the questions we needed to ask. I'm going to give you two more things from our data just to round out the story. So this chart, it may look like there's nothing there, but there is a blue line. If you look at it, it goes straight down and then straight across. And this is just a frequency ranked list of our diagnostic codes in our database. So the most used term in encounter diagnoses from that list of about almost 11,000 terms was HIV. Our second most frequent term was used almost it was a little bit more than half as much. So it was closer to 6,000 times. And that was for Hep C, once we've done a little bit of cleanup. Can anybody think why those two were the most highly coded terms? And the answer isn't that they were the most prevalent reason for visit. It was common. It is common, but it's not the most common thing we do in our practice. So any ideas? Pop in the chat or unmute, please.
Maybe because in every encounter they were re-entering the diagnosis. So
yes, we enter the diagnosis. In the encounter, we have an assessment, or I don't want to say reason for visit, but it's our assessment. And so yes, I mean, best practice is actually to say, I saw this person for HIV and whatever the other terms are, so that you can then do this kind of tracking later on. So yes, many people with HIV would have had the same diagnosis, multiple visits over the year or over the many years, which is good practice. So yes, so that's part of it. We see people with HIV more frequently. Other ideas?
I would hazard a guess that it's possible they were the first two diagnoses on the list.
Ah. No, the list is alphabetized. So when you just load it up, and it's actually, that's a fairly good search. So no, but a good guess. The two reasons I think, one is that a lot of our HIV and Hep C care is managed with our nursing staff, who are much more diligent. But the biggest reason is that those are two areas we do research in. And so there was this very tangible reason to keep documenting those things, because it tied into research projects and research funding. And that's hard for you to know, but those are like the reason for coding, the value of coding it in properly, was just really apparent to all of us. So people started doing it properly near the beginning. So interestingly, about 543 diagnoses were used more than 50 times out of that 11,000. That's not uncommon, that you've got this big cluster of a couple hundred diagnoses in primary care, because we are a generalist specialty, we tend to cluster, and different practices cluster in different ways, but so we tend to have a few hundred codes, or half 500 codes that were used a bit more often. But we have this incredibly long tail. We have more than half of the terms were only used once in our database. And that's the thing I want to highlight here. It's a little bit more data quality, but here are some ones that popped out. So just 150/78 sitting. That would be, if I'm reading it correctly, a blood pressure measurement, not a diagnosis. It may imply a diagnosis of hypertension, but it is actually just a physical exam measurement. Sinusitis back pain, which I believe is a combination of some sort of home renovation accident that caused some problem with breathing and clogged sinus, but it could in fact be a combination of back pain and sinusitis in the same visit, which should be on different lines. And then my favorite one was, he denies any real change in condition, which I don't actually know what that's supposed to refer to, but it is then coded into our database, which is staggering. So how do we end up with this? Our EMR offered flexibility. It was not a bug, it was a feature. Here I'm typing in hepatitis, to go back to our first example. So this is some strange orthopedic gastrointestinal condition that affects both your hip and your liver. I don't know, but it's just a spelling mistake. And when I pressed enter to search for the term, this is a little pop-up window. And just notice which of the two buttons was already pre-highlighted. I didn't do that, but the yes button was there as the default. So we got in the habit of pressing enter twice. So that window pops up, you press enter again, and it just goes away. If you intentionally move your hand to the mouse, go to the no button, click, it then you go through a series of several strange dialog boxes that essentially says, are you sure you don't want to? Are you really sure? Are you going to change it? Do you want to add it as free text? And because you made a spelling mistake. So my finger slipped and I hit the I instead of the E, and it didn't find the right term. And now suddenly I've added in hepatitis into the database, or hepatitis, or heroin with an E, or whatever it is. And this is happening, what was happening in this system all over, and wasn't the only system. The reason it's not the only system is that the EMRs were offering flexibility. And they were doing that because we were asking for it as clinicians. And that is happening still today. So lots of things where people are saying, I don't like the standard because it's hard to use, so give me another option. And that is sort of part of this story. And the reason we asked for it back then, thankfully, has changed a bit in the last 15 years. But we were paper trained. So while clinicians are smart, they were thinking about the record as an electronic paper record, a version that needed to be read, and that was all. And so it was great because the vast improvement over handwriting, right? especially physician handwriting. I'm gonna bug my colleagues here. That's the old story: is your handwriting is so bad that you became a physician. So now we fixed that problem. Big improvement. But if you think about it as a Word document, you're not going to be able to find the stuff that you need to do the rest of it. So we ended up with these sort of standards that were put in place for billing, and then this weird kind of mashup afterwards to try to meet the demand of people who didn't quite understand what they were doing in the short term and the impacts in the long term. And I've looked at enough practices over the last 20 years to see that is, while I showed you some examples that were perhaps unique to us, they were certainly not unique as concepts. So that's the horror story. I'm going to shift gears to talk about how standards can be helpful. And when Francis and I talked about this, the joy of doing a guest lecture is I can talk about whatever I want. But we wanted to talk a bit about sort of some of the work from the trenches. So, I've had a whole range of things that I've done over the first parts of my career, from in hospital, working on wards, to in practice, working with EMRs, to regional information system design, to provincial standards and procurement of systems, to national standards. So a whole range of different things over the years. My work now is much more focused on health system change and less about information systems, but of course there's lots of overlap. So I want to talk about 6 different areas where data and standards can be helpful. And you sort of use this as the frame for the second half of this talk. And really, these are half are care and half are care adjacent. And I'll try to bring in examples, and then as we go along, answer questions if you have them. So first, point of care. So point of care, I think, is certainly where I've focused in my initial interest in data standards and trying to see what we can use and why we're using what we are. And as I've thought about it over the years, sort of a nice frame to organize it. There's terminology standards, absolutely, very important. But there's other things too. And to sort of step back a little bit, there are structural standards. So by that I mean sort of the info structure of the content. So it's not just the terminology set that I'm using for diagnosis, but it's the fact that there is a note for every visit, and within that note there are certain components, and those components then are tagged. So there's that structure to it that is then standardized, as well as then the terminologies slotted in at the appropriate places. Along with that, though, are the behavioral standards. So there's the documentation practices, and do you need a diagnosis for every encounter? If not, why not? Do you need to write your prescriptions on paper, or can you write them in the EMR, or do you have to do both? Those sorts of things are those sort of more practical standards for behavior of documentation, which without those, you're not going to be writing stuff in the chart. And perhaps they are a way to think about change. And then there's clinical practice guideline standards. So what should I be doing? What are the goals of treatment and care more generally? And then having those then feed forward into those different layers. So it's really interesting in BC, in primary care, that our primary terminology standard, has anybody here, before I give the answer, has anybody here worked in terminology standards in BC, probably any province in Canada, or at least most of them, and has an idea of what the most common standard is for primary care in terms of data terminology standards?
Guys, you can either type in the chat box or just speak up. You stumped them again.
Okay, so it starts with an I. No, it's ICD-9. ICD-9, Francis, you correct me if I'm wrong, but my understanding is that it sort of was replaced by ICD-10 in the 1990s. think from a CDC perspective in the US, for even just mortality tracking, they stopped using ICD-9 in the 90s.
That's correct. In Canada, we moved to ICD-10C in 2002.
Right.
But the move wasn't completed until 2005 or something.
And I'm still using, 2 days ago, ICD-9. So just to be clear, it hasn't quite happened in community yet. In the hospitals, we're using ICD-10, but in community, we're using ICD-9. And by community, I mean also other ambulatory specialists, so dermatology and ortho and what have you. What's fascinating, I mean, not only is it archaic, I think it was originally proposed about the time I was born and was supposed to be deprecated 20 years ago. And now we're technically at ICD-11, but it is not meant for clinical care. The C stands for classification. So it's a classification standard, not a clinical terminology standard. And that's a really important distinction. So Julie's got ICD in there for sure. Maria's added SNOMED. So the difference between SNOMED and ICD is SNOMED is really more of or at least SNOMED CT is clinical terms. So it's a clinical terminology, and as opposed to a classification system. So when I see a patient, and they have an infection of the hand, they have cellulitis, I need to know I need to describe certain things if I'm going to be working in a team, or if I'm going to be following up with this patient or expecting to follow up with them at some point in the future. So I need to know it's cellulitis of the left hand. I need to know how far up the arm it goes, how many centimeters, is there streaking, is there not streaking? And that's not in the several thousand item list that is ICD-9. It is in the multi-100,000 list and with post-coordination of SNOMED. But we don't use SNOMED. When we were procuring EMRs for BC, we did have a requirement in there that unfortunately got worded, have the ability to implement SNOMED. And all the vendors said, yep, we have the ability to insert the SNOMED table in, the list into our table, but then they didn't actually. So we got stuck with ICD-9 because we have ICD-9 because of billing. I'm going to get to that in a sec, but so there's a historical reason why that was there. So I think it is really important to think about the purpose of the standard. And in point of care medicine, like point of care, standards can be really helpful. And I'm going to sort of focus a bit more on terminology here, because you then have that specificity, but you also then can use that to drive different kinds of alerting. So clinical decision support. It can help with selection of medications, et cetera. That I think is really an important feature, even though there are pros and cons to using decision support. But decision support doesn't have to always be that traditional kind of pop-up alert that blocks you from doing things. I think that's should be used only very rarely, but it can help with augmenting what you're doing, and that comes into the areas of supporting different kinds of workflow. If there's a particular condition, it reminds you to do certain things, and to be proactive and follow up and reminders. So it might be very easy for me to say, yes, if I have to remember one thing, is that this person has to come back in 3 months, not 6 months, because of their kidney function. But in the heat of an encounter where we're dealing with something that's quite intense that is not related to their kidneys, I might say, okay, well, I'll see you back whenever, in 6 months, and then I realize after the fact, oh, that's right, we need to get their blood work done. And that's where the right alerts that are driven by the right terminology can support that sort of proactive workflow. And I think that is a key thing. So we talked about ICD as how it has certain challenges. It also has some other challenges in primary care, just to highlight. It's the third letter. So I'm going to take no issue with international classification of disease, but I've taken issue with C and D. So it's disease, and primary care deals a lot with not disease. So we have a certain amount of functional medicine that we do. We have a certain amount of undiagnosed symptomology that will present itself in time, but today it's a cough. It'll be pneumonia if the X-rays prove as such, but I can't diagnose pneumonia until I've done that. And in a hospital, in an emergency, it's generally you have that working hypothesis. You get the X-ray right then and there. In primary care, we don't. So, or not always. And so it might be the next day or 2 days later that you get the result back. And then you go, oh, goodness, okay, it was, in fact, pneumonia. I need to call the patient back. But those things are actually connected. And ICD doesn't give you the opportunity. There's not a code for there's not great codes for not diagnoses in ICD. So that's one of the challenges. So there is another terminology set that's out there, is the International Classification of Primary Care, so ICPC. And that gives us the breadth, which is great, except it doesn't give us the depth. So that's where we come back to that clinical terminology versus a classification system. Other clinical terminologies that are out there that we do use in primary care, indirectly we use things like LOINC codes, because that comes through the lab system. So that we sort of have a lot of this embedded because of what we receive. And then our drug databases often will be connected to some terminology set that is relatively exhaustive in terms of the different medications. It can be too exhaustive and coded at the wrong level. And by that, I mean, sometimes the terminology sets are actually down to the package, not just the medication and the medication strength, but the actual, is it 10 tablets or the 20 tablet pack? Those have two different codes. So it doesn't make any difference to me which package they get. It's more the active ingredient level that's important to primary care. All right. So then these will go faster, don't worry. Moving into shared care. So what I wanted to highlight here is some of the work we did around electronic referral and electronic summaries used in referral, and also at the shared health record level at the province. So I also include in shared care the use of a personal health record. So I think that's a really important thing to remember, is that patients generate data as well, and they will use certain standards in their personal health record, a personally controlled health record. But I'm going to focus on sort of the data sharing around shared care between providers. What we regularly forget is the closed loop. And by that, I mean, when somebody's referred from me to a specialist, there's always a return. And we don't have a great standard approach to managing the round trip of that data, that bidirectional transfer. In our lab, we've done some work around bidirectional transformation of patient data summaries through referral. And it's not a wicked problem, but it's a really important problem to work out. And we don't do that well at all. We end up just sort of throwing our version of stuff over, sometimes as a PDF file, so standardized to the PDF format, but not, and standardized headers and stuff, but the actual content isn't standardized. And then same coming back, we standardize to getting the document as perhaps it's in a message, but then it's a blob in the middle, so it's not really standardized. But when you get down to that third level of coding and standardization of the data, what happens when you are when I code the diagnosis a bit more generally, and my colleague down the road codes at a slightly more specific level, right? So just really a simple example would be, I code for cough, and then the patient is seen, or the X-ray is seen by the radiologist, and the radiologist says consistent with pneumonia. So is my cough and pneumonia the same problem? And how does the system then marry those across? Even if we're using the same terminology sets. So assume there's no other sort of translation hiccup there, but the level of specificity is different. And so we haven't done that round trip. So then when I get that EMR back, or the report back in my EMR, does it sit somewhere, or does it get integrated into my EMR so that I now have sort of augmented my own data? Ideally, we're leveraging shared care to augment, not to sort of fragment. And right now, the reality is we're doing a lot of fragmentation. Of specialist has a different diagnosis list than I do. We each manage our own medication list. They're not harmonized. That stuff is really a challenge, and standards can help with that, but we have to think of that flow. All right, very briefly, billing. We do this actually, we know how to do this. This is not incredibly complex, and this has actually been the driver for much of the data we have in the system from primary care in BC, at least. As I mentioned before, we're still using ICD-9. We have to, in BC, in primary care, have a diagnosis code to every billing, not just an activity code. So I saw this person for counseling, or I saw this person for a mole removal, but then there also needs to be attached 1 to 3 diagnoses. The reason we have that is to help with system planning. But what ended up happening in a lot of places in Canada and elsewhere is that because that was required, then the keen and flexible vendors said, well, let's use it in other spots, because we can leverage that in different ways. And that's why ICD-9 sort of propagates all over the place. So I think we've leveraged it too much, but that is where it all started from years and years ago. I'm going to spend a moment on the point of reflection. And I kind of alluded to this in my horror story at the beginning, but it's that mythical time at the end of the day when, I don't know, you have free time in your practice and you go, oh, I'm going to just think about how am I doing? What are we doing? And what could we improve? So it's connected to quality improvement, absolutely. And when I say, mystical time that we have at the end of the day, I mean, we're also busy, but we do make time for quality improvement at different levels in different ways. But what we have is a challenge when we get inspired to do something, and then we run back to our office in our EMR or log in from home after the conference, and then, or sometimes even I've done this at conferences with a secure VPN, of course. And then I start saying, okay, well, I can do that for our practice. And then I realize, oh, right, there's 34 misspellings of hepatitis. And often these QI activities with EMRs either become a data quality QI. So now my first couple of learning cycles are going to be related to how do I correct the spelling of hepatitis? And that's much less rewarding for a clinician who wants to see the change in practice. And now I can start recalling patients and save lives, which is wonderful. And when I've done that, and I've been able to show that in a research project, that decision support saved lives, is so rewarding. But now I'm going to be doing cleanup. Right? It's like, so it's that's a real problem. And yet it's absolutely necessary to get us past. The other thing that happens is people will shift away from the EMR data. And if they have to, they'll figure out something else. So here's an example of an emerging problem that happened. And I can share this graph because it got leaked to the press. This is from our community health center. We support a number of housing units around Victoria. And we had an outbreak of COVID last year. A cluster is what it's called in BC. Because it's not in a facility, but it was in multiple housing units. We needed a way to track this. And even though we had put in codes in our database for COVID early on, we added customized ICD-9 codes before the province and the country had decided what code to use. And we had a certain level of information there, or data there. We couldn't extract it. So we end up doing this all through spreadsheets. So that's the other thing that'll happen is if your standards and your workflows don't support it, you end up hacking the system and doing chart reviews and then pulling data out. So, and which we needed to do because we really needed to track this very rapid spread across multiple units and housing and all that. And that's how we did it, is we ended up having to pull data out of our EMR manually, effectively doing multiple kinds of chart review, which was too bad. Yeah, so that's one example. And then policy development. So we talked about how the billing data is used. What I think is interesting about policy development is that they do have multiple sources. When I've been involved in this, you can look at different things, but you roll up the data quite a lot, and that's where ICD is sometimes even can be too specific for some things, and so it's less of a complaint from that group, but the data quality and the missing data is often the complaint. There's ways to sort of enhance the data, pulling together multiple sources. As long as they share a reasonably compatible standard, then you can start to look across them and say, well, if the hospital had a diagnosis like within these categories, or community had it within these categories, then we can build a probabilistic list of patients with a certain condition. And CAI is, of course, one of our preeminent organizations that does this. However, not all our data standards are compatible. And even ICD-9 and ICD-10, same family, you cannot translate 100% between the two. There are certain codes in ICD-9 that are too broad, so to what is in ICD-10, because ICD-10 tends to be more specific. But worse than that, there are some codes that, because of restructuring, actually overlap more than one other code. So it's not just it's not just a one-to-many relationship, but it becomes a many-to-many relationship. So you don't know which bucket the diagnosis falls into. So you have to make some estimates, and that's a real problem with standards when they're rolled up to that classification level, and then they're not compatible. So just as another flag, and I've seen that be a challenge. You can accept a certain amount of error when you're talking population level stuff, which is very different than primary care or like point of care, where if something is wrong, it's not just a percentage error, it's wrong for that one person. So I think that is one thing just to flag. So you can tolerate a little bit of that, and like I said, you can do some augmentation by triangulation. And number 6 is research. Interestingly, are there data standards in research? Absolutely there are. There are often protocol specific standards. So everything within that protocol, is standardized, but it's not necessarily standardized to a regular practice. And so you end up using these wonderfully, and I do this all the time, these wonderfully validated tools that are not being used in practice. So you do a whole separate standardized data collection just for the research. And I'm talking more clinical trial type research. If, however, you can use the existing standards and the existing data, then it gets very cost effective. It's not cost effectiveness research, it just gets much cheaper to do the work. And I don't know if anybody has heard the very clever acronym CPSSN, which is CPCSSN, which stands for one of two things: the Canadian Primary Care Sentinel Surveillance Network, or it's the Canadian Primary Care Surveillance Sentinel Network. I think it's the first one. And it's funny because I've worked with them for years. The CPSSN database takes EMR data and then is able to do some sweetening using some standards to augment the coding, and then they can leverage that for a whole bunch of really interesting research relatively cost effectively once it's in the network. So research has its own internal standards to a study. If you can leverage reasonable quality of data that in existing standards, that can be really, really valuable. And when we built a research network, CPSSN's one, we built another one. It's surprising how quickly you can answer certain questions. Again, you have to do things like check the quality of the use of the standards. All right. I'm going to stop there, I think.
Okay, well, thank you so much, Morgan. I'm going to turn the recording off as this concludes the presentations portion of the session tonight.